now we're going to talk about the inherited hypercoagulable states. So first, this could be due to mutation in the genes that codifies for protein C or S, dysfibrinogenemia, factor 5 Leiden, antithrombin 3 deficiency, prothrombin point mutation in 2010A, to 20,210A mutation, and increase in homocysteinemia, hyperhomocysteinemia, congenital causes like deficiency in the methyl tetrahydrofolate reductase enzyme, for example. Alright, so in protein C and S deficiency, the problem is, remember that protein C destroys more important to factor 5 and protein C to factor 8. They destroy also two other coagulation factors, but think about this. So if the patient, if a patient that is deficient on this enzyme is not going to destroy the coagulation factor, and so there is increase in the coagulation cascade, and so the patient has thrombi formation. We could see this, for example, protein C deficiency is more common than protein S deficiency, and we would see this most commonly when the patient, a female patient, is undergoing a hormone replacement therapy or oral contraceptive pills, and after that they present with a thrombotic event. And certainly the treatment would be not to take those therapies. In factor 5 Leiden, this is the most common cause of inherited hypercoagulable states. This is a defect in the factor 5 near the cleavage site of protein C. So protein C can no longer cleave factor 5. So it's a factor 5 that is resistant to the cleavage of protein C, and so there would be increasing the activation of the coagulation cascade. This is a mutation in which guanine is exchanged for adenine, and this results in arginine being exchanged for glutamine in the position 506. They will present with deep vein thrombosis or cerebral sinus thrombosis, pulmonary embolism, and usually would be seen in a middle-aged patient, usually, for example, a female 45 years old, or in or thrombosis in atypical presentations. Then, after factor Leiden, the second most common cause is the prothrombin mutation. This is a mutation in the 3 untranslated region that leads to increase in the gene expression of antithrombin 3, and this in prothrombin, and the increase in prothrombin, that is a coagulation factor, the coagulation factor 2, would lead to increased plasma levels of factor 2 and thrombus, vein thrombosis. This is the second most common cause, and is a point mutation. The others that we saw, the factor 5 Leiden, this was the autosomal dominant mutation. And the others that we're going to see, the antithrombin 3 deficiency, is also autosomal dominant. This is a deficiency in antithrombin 3, and remember that antithrombin 3 destroys factors 2, 10, 9, and 12. So if we have a deficiency in antithrombin 3, we could not destroy these coagulation factors, and there is increase in the coagulation cascade, and so thrombosis of the arteries and veins. Also, if we give the patient heparin, we will not see the increase in partial thromboplastin time, or would be very little increase. So we would need higher doses of heparin to achieve the increase in the partial thromboplastin time, or we can give Coumadin. Coumadin should be given in order to maintain the anticoagulation state in the patient. Coumadin also inhibits the intrinsic pathway, so we will see the increase in the partial thromboplastin time. There could also be acquired antithrombin 3 deficiency. Here we are talking about the inheritable causes of hypercoagulable states, but just be aware that also antithrombin 3 deficiency could be acquired, for example, in nephrotic syndrome, in which the proteins are being lost in the glomeruli, for example, the antithrombin 3, and so for that the patients have a hypercoagulable state when the patient has the nephrotic syndrome. So the inherited hypercoagulable states are the most common factor 5 laden, that is mutation in the point mutation from arginine to glutamine because guanine changed to adenosine, and this presents in atypical presentations of thrombosis or deep vein thrombosis, cerebral sinus thrombosis. The second most common is the prothrombin mutation that presents with vein clots and is a mutation in the 3 untranslated region that leads to increase in expression of prothrombin. Protein C deficiency could be seen after hormone replacement therapy or oral contraceptive pills, and antithrombin 3 deficiency would reveal a decrease in the increase in partial thromboplastin time. Now, usually in the hypercoagulable states, we treat them for 6 months with warfarin. That is, when the patient presents with a clot, we first need to give heparin or direct inhibitors of thrombin. Usually we give heparin, but for example in hypercoagulable states that are produced, for example, for heat, heparin-induced thrombocytopenic that's present with life-threatening bleeding and sometimes thrombosis. But when heat is presented, we cannot give heparin, and so we need to change for direct thrombin inhibitors. So in any case, in a hypercoagulable state in general, first we give heparin or direct thrombin inhibitors, and after 5 days or so, we give 6 months warfarin. Only if it's the first clot. If they present with more clot, sometimes we give lifelong term anticoagulation, but usually don't. For example, for factor 5 laden, we give warfarin for 6 months, and the goal is to get the INR to 2 or 3 instead of 1 or 1.5, that is the normal in a patient that is not on anticoagulation.